Welcome to the Quality Payment Program Overview. Over the next 10 minutes, I'll summarize the main points of the program and provide you with some helpful resources. Keep in mind that you'll have more learning to do, and you can turn to the Lake Superior Quality Innovation Network as well as CMS, the Center for Medicare and Medicaid Services, for support, detailed information, and answers. Our objectives today are to familiarize you with the goals of the Quality Payment Program, provide an overview of the program basics covering the two primary paths, and then share with you the support services that are available for Minnesota participants. As a disclaimer, content provided in this presentation is based on the latest information made available by the Center for Medicare and Medicaid Services and is subject to change. CMS policies change, so we encourage you to review specific statutes and regulations that may apply to you for interpretation and updates. The Quality Payment Program is aligned with CMS quality strategies at the national level, including achieving better provision of care, helping individuals and communities to be as healthy as possible, and smarter spending, attaining higher quality at the most reasonable and lower cost. Currently, the majority of Medicare Part B services are paid for on a fee-for-service basis. The Quality Payment Program serves as a framework to simplify, combine, and harmonize several reporting programs and position practices and clinicians to take the next steps toward population health and graduate to the type of payment models that correspond to and support the aforementioned strategies. Within the Quality Payment Program, these are known as alternative payment models, or APMs, and we'll touch on those in just a few minutes. The diagram depicts the Quality Payment Program at a very high level. The program originates from legislation known as MACRA, the Medicare Access and CHIP Reauthorization Act, and breaks down into two paths that you see here. MIPS, the merit-based incentive payment system on the left with its 4 reporting categories, and alternative payment models, both MIPS APMs and advanced APMs on the right. CMS estimates that roughly 92 to 95% of Part B eligible clinicians, the designation given to providers under this program, will report through MIPS, whereas the remainder will participate in advanced alternative payment models and are known as qualified participants. You'll see in the diagram that some eligible clinicians will participate in MIPS APMs, which I'll describe shortly. The merit-based incentive payment system is broken down into 4 categories, 3 of which were prior CMS programs that have been discontinued for providers eligible to participate in MIPS. The quality category replaces PQRS, the Physician Quality Reporting System, and accounts for 60% of the overall MIPS composite score. Improvement activities is a new category and makes up 15% of the score. Advancing care information is the evolution of meaningful use, the EHR incentive program, accounting for 25% of the total score. Lastly, cost, or the former value-based modifier, is not included in 2017 MIPS scoring and is under consideration for inclusion in following MIPS program years. MIPS eligible clinicians include physicians, nurse practitioners, physician assistants, clinical nurse specialists, and certified registered nurse anesthetists. Physicians are required to report on 3 MIPS categories: quality, improvement activities, and advancing care information. The other eligible clinicians listed here are only required to report on quality and improvement activities, but may optionally report on advancing care information if they elect to do so and you are able to collect the needed data. CMS envisions expanding the list of eligible clinicians after the first few years of running the program. In addition to the types of clinicians that are required to report, as we saw in the prior slide, there are also MIPS eligibility thresholds pertaining to the amount billed or the number of beneficiaries that receive services within a performance year. While not covered in this overview, group reporting is an option you may wish to consider, and these thresholds are identical for either a single eligible clinician or a group. A group is composed of 2 or more eligible clinicians associated with a tax identification number. The minimum thresholds are $30,000 of Medicare Part B allowable charges and a minimum of 100 Medicare Part B beneficiaries per year. Both of these thresholds must be met or exceeded on an annual basis to be considered eligible for MIPS. Again, these thresholds apply to both the individual or group reporting levels. Eligibility information can be easily obtained through the QPP NPI lookup tool at the website listed here. By entering an NPI number, you'll see whether a clinician is eligible or exempt from MIPS participation and also whether that provider is eligible at the group level to participate. On the other side of the coin, let's look at who is exempt from MIPS. If you are a clinician who bills less than $30,000 a year in Medicare Part B allowable charges, or provides care to fewer than 100 Medicare beneficiaries, you would be exempt. If a clinician is below either of these minimum thresholds, they are considered to be exempt. Also, if a clinician is significantly participating in an advanced alternative payment model, they would be exempt. Significantly participating is defined as 25% of Medicare payments paid through an advanced APM or 20% of Medicare beneficiaries seen through the advanced APM. Additionally, the first-year enrollees in Medicare are exempt along with non-patient-facing clinicians, those who have fewer than 100 face-to-face visits in a year. MIPS APMs are one of the two models within the alternative payment model path of the QPP program. MIPS APMs are the middle ground between reporting all the MIPS categories as an eligible clinician and participating in an advanced APM. There is no downside or negative payment adjustment when serving patients attributed to a MIPS APM model. Examples include, but are not limited to, the Medicare Shared Savings Program Track 1 or the Next Generation Accountable Care Organization model. A benefit of MIPS APM participation is not needing to report on the new improvement activities category. However, quality and advancing care information reporting still must be submitted. MIPS APMs and advanced APMs, to be discussed on the next slide, have unique scoring considerations and methods of reporting. Remember, CMS's goal for QPP is to help participants graduate from the basic MIPS reporting path to an advanced APM model. The second option under the alternative payment model path is the advanced APM. These models further promote movement away from the fee-for-service payments by increasing the upside incentives and introducing downside payment adjustment risk. MIPS reporting is not required as long as 25% of Part B payments or 20% of Medicare beneficiaries are served through the model, and qualified participants, QPs, are rewarded with an annual 5% lump sum bonus as an incentive. If a clinician does not meet the 25% or 20% payment or beneficiary thresholds, they are then scored under the middle ground MIPS APM scoring standard. Examples include, but are not limited to, Medicare Shared Savings Program Track 2 and Track 3. CMS has also created a pathway to introduce new and innovative APM models, which are reviewed and approved through a committee process. Let's take a look at the MIPS payment incentives as compared to prior CMS reporting programs. The left-hand side of this infographic shows the years in which payment adjustments were and will be applied under the Meaningful Use, PQRS, and Value-Based Modifier programs. The payment adjustments for these programs conclude at the end of 2018. The programs had negative payment adjustments that were cumulatively stacked and applied to Medicare Part B payments, and also featured a smaller total positive payment adjustment, seen in the light blue boxes on the left, than you see under the MIPS model, the gray bars above the line on the right. 2017 is the first year of participation under MIPS with the same 2-year lag as the prior programs, after which the payment adjustment is applied. Therefore, 2019 is the first year of MIPS adjustments, and you'll see both the negative and positive payments progressively increase from 2019 through 2022. These MIPS basic payment adjustments are revenue neutral, meaning those who do well will be paid out of the pool of negative adjustments for each program year. The green upward arrow for each year on the right represents a special $500 million annual exceptional bonus fund paid out to those who perform the best each year and will be available from 2019 through 2024. This timeline graphic shows the progression of payment adjustments under the fee-for-service, MIPS, and advanced alternative payment models. In the fee-for-service row at the top, you'll see the Part B physician fee schedule increases uniformly at 0.5 or 0.5% per year until 2019, after which there is no annual increase until 2026. At that time, the increase will be set at 0.75% for participants in advanced alternative payment models and only 0.25% for all other Medicare fee-for-service providers, clinicians who are still reporting through MIPS. The general takeaway about the MIPS row in the middle is the same as on the prior slide. A progressive 4 on up to 9% maximum payment adjustment from 2019 through 2022, which then remained fixed beyond 2022. Advanced APM participants, or qualified participants, see a 5% lump sum annual payment along with whatever incentives are included in the APM model, along with the exclusion from MIPS reporting. These are the highlights of the Quality Payment Program in just about 10 minutes. The following 2 slides discuss how we support you in your participation efforts and point you toward helpful resources. Stratis Health is one of 3 state partners in the Lake Superior Quality Innovation Network, along with Wisconsin and Michigan. It's our goal to support all clinicians and practices across the state of Minnesota to successfully participate in the Quality Payment Program. We serve you as a trusted advisor, and we offer introductory and advanced education about the Quality Payment Program, individualized technical assistance, including assistance estimating a MIPS score using our MIPS Estimator scoring calculator, which you can use at no cost, support for quality improvement through resources, data analysis, and best practices, as well as keep you abreast of CMS program and resource updates. If you need assistance with the Quality Payment Program, here is our contact information. You can email our Minnesota QPP Help Desk at qpphelp@stratishealth.org, visit the Lake Superior Quality Innovation Network website at lsqin.org, or navigate to our Stratis Health website where we host the MIPS Estimator calculator at stratishealth.org. And lastly, be sure to visit qpp.cms.gov, the primary website for all CMS Quality Payment Program materials. Thank you for your time today, and we wish you and your practice success as you participate and engage with the Quality Payment Program.